Okay.
Hello, from Great Britain, James Roach here, at what is my 5th Senior Care Science and Innovation global event. Very sad and disappointed that I can't be with you today to see you all again and share experience and insight, but welcome the opportunity to present to you today, and hopefully we can keep in touch around the virtual event, and very happy to deal with any questions and follow-ups from the session. My presentation this year will focus on the impact of COVID-19 in the UK, lessons and next steps, what we've learned, what we can share in terms of key learnings, and how China and the UK could work together differently in the future. So I'm going to start with the wider impact of COVID-19. And beyond healthcare, we've seen both economically, from a social care perspective, from a family perspective, from a business perspective, from a mental health perspective, there's been a significant impact on the way we live our lives in the UK. A number of our schools have to close, and they're only just starting to reopen now, and that's clearly had an impact on educational attainment. More children have had to be educated at home. More children have had to use virtual platforms by which to educate themselves. And that's created a wider dilemma in terms of how we best educate our children moving forward, and making sure that they're not being impacted academically, socially, and mentally by the pandemic. Unfortunately, what that's meant is the inequalities in relation to education has widened. The gap between rich and poor in terms of educational attainment has increased. And that's had a real impact in terms of the development of children at key ages, at key stages in their academic development, the way in which they can undertake examinations and how they're graded moving forward. There's been a massive employment issue in the UK, number of people who have been made unemployed or redundant from their work, and those who have been supported through furlough. And furlough is a government-backed scheme in the UK whereby the government guarantees a percentage of employers' wages to keep them in employment. What we're beginning to see now at the end of the furlough programme in October is more people potentially being out of work, certainly an increase in work-related stress, and that's had an impact on mental and physical health as well. We've also seen an increase in bad habits during this time. Alcohol dependency has increased. No doubt dependency on prescription drugs has increased. And that's had an impact on behaviours, the family unit, and society as a whole. And I think this is probably one key area which we can learn from globally. How do we bring data sets together to best understand the true impact on the individual, their family, and the community that they live in? The other lesson I think we've learned in the UK, particularly when it comes to epidemic management, is that the true sort of recovery will take time. It will take time from a health perspective. It will take time from a prevention and public health perspective. It will take time in terms of education and mindset. It will also take a long time for our economy to get back to the level it was pre-COVID-19. And what we've started to do now is draw parallels from the 2008 global financial crisis. And certainly what happened during the 2008 global financial crisis potentially could happen again as a result of COVID-19. What we saw in relation to sort of financial circumstances driving health was that people having material disadvantage, the most deprived in our community, not having equal access to healthcare, not having equal access to social care, not understanding the need to sort of protect and manage their own health condition, having a real impact in terms of how they engage with the health system. And I think the frustrating thing is, looking back, that all of that was avoidable and preventable. And one of the key lessons from the UK in relation to COVID-19 is how we pull together information, data, and insight into one place to understand the true impact on the individual rather than just focus on their healthcare needs. There are some slides, there are some links in the slides that you're welcome to look at your own convenience. The article at the top of this slide starts to look at the sort of comparison between Europe and America. And I think what we are seeing, particularly what we are very concerned about in the UK, is as we go through COVID-19, we're likely to see an increase in the number of long-term conditions reaching a serious point because they're not being managed as proactively as they could be. There are particular concerns about the incidence of diabetes and respiratory conditions and cardiac conditions. And the fact that practitioners have not been able to manage that as proactively as they would have liked will have an impact on the long-term health of those individuals. Beyond that, we're starting to see that slow, long-term impact on mental health. And what we are expecting in the UK, particularly over the next 18 to 24 months, is a significant increase in patients with chronic long-term conditions who need management now, and underpinning all of that, an increase in people with diagnosed mental health who will need support to get on with their life and remain economically active. Within the UK, there's a population of 56 million, and we've broken down the key population groups, if you like, during the COVID-19 pandemic. We have those that are socially vulnerable, and we've spoken about those in the previous presentation. Those that can't access healthcare, have a low income, live in a particularly challenged neighbourhood and environment. We have a number of citizens with unmet social needs who have not yet identified themselves, or who previously, pre-COVID-19, because they had employment and because they were part of an education process, were able to get their needs met. As their situations become more challenging, those social needs have become greater. So potentially the socially vulnerable in the UK as a result of COVID-19 is likely to increase. That's on top of the fact that we have calculated that there's circa 1.5 million people in the UK at risk of COVID-19, and that's likely to increase as the focus on shielding patients increases accordingly. Populations post the COVID-19 pandemic, we're expecting to see a real step change. And in red on the left-hand side there is we expect citizens with unmet social needs to be in the majority. So we're expecting to see more people experiencing health inequalities, more people finding it difficult to manage their long-term conditions, more people with underlying mental health issues, and more people who require social services, public or charity services in the future. What do we need to do? So what we're looking at, and health is only one part of this, of course, what we're looking at is a multi-sectorial approach in terms of improving people's status post-COVID-19 and minimizing the impact of COVID-19. So what can we do to sort of generate an active labour market? How do we support families more? Not just those with clearly defined social needs, but those we believe are at risk of an increased healthcare need or mental health need or academic need or employment need in the future? Do we need to be more proactive around the use of alcohol or the provision of prescription-related drugs? Do we need to provide more care in the community for those people we know are at high risk of long-term conditions or mental health problems? Underpinning all of that, of course, is the need to support our healthcare staff. And we believe it's absolutely critical that as well as keeping our healthcare staff supported and in work to provide services to the population as they need it, we're also invested in them as individuals. So what else can we do to train and support the healthcare professional so they're more equipped to deal with the patient's holistic need, whether that's health, social, societal, environmental, or even financial? Is there more we can do around bringing key social and healthcare information together to determine need? How do we maximize that patient's interaction with the healthcare professional or the counsellor or the government official to get all of that key information in one place? And how do we coordinate responses across the whole sector? This isn't just about hospital, it isn't just about the general practitioner, the pharmacist, the carer. This requires a whole health and care system approach. And certainly what we have learned in the UK during COVID-19 is the absolute need to coordinate responses across a whole health system. And the response to COVID-19 has really broadened and deepened our approach to integrated care in the UK. And again, I believe there is an opportunity for both China and the UK to look at how they can best sort of connect their health and public health and care services in the future to best meet the needs of the population moving forward. The next section will focus on some of the numbers across the UK and the statistics and what that means. So in terms of the worldwide position, and obviously China will be very aware of the high number of cases globally, we've seen just probably 15 million cases worldwide, probably up to around 700,000 deaths worldwide. In the UK, we've had circa 300 to 350,000 cases, and around 45,000 and 50,000 deaths. Over 2.2 million people were asked to shield in the UK, and 9.25 million workers in the UK were put through the furlough scheme, which again is where the government secures the wages of workers so they don't become economically disadvantaged. And the average age of death from COVID-19 in England and Wales was 80.4 years of age. So it's very much been an elderly care issue. But as we come out of the first wave of COVID and into the second wave of COVID, it's absolutely clear that this is an all-age issue, and working age adults and young adults in particular are now the at-risk cohorts. Just a summary of the key sort of COVID-19 expectations in the UK. What are we expecting to see in terms of impact? Number one is direct COVID-related mortality. We've seen around 50,000 deaths in the UK. Two is indirect related COVID mortality. So patients who haven't been able to access healthcare services, haven't been able to receive the general health support they require, we expect to see an additional 12,000 to 25,000 deaths as a result of that. There's been changes to healthcare activity as a result of hospitals not being able to undertake operations or provide diagnostic tests or provide medicine-based care. That potentially increases the risk of death for a high number of high-risk patients, and the numbers there are listed. And not forgetting the long-term pandemic and economic impacts of COVID-19, where you could see deaths related to a fall in income, a fall in employment levels, and an increase in mental health challenges. The slide in front of you just gives you a breakdown of excess deaths in the UK. Clearly at week 14, 15, and 16 of the pandemic, we saw an increase in terms of the reporting. So reporting of deaths had improved, but clearly we'd seen an increase in the number of deaths as the pandemic reached its peak. And we believe there's 14,000 excess deaths between week 13 and week 20 on the graph. So that just gives you a breakdown of the deaths week by week, and it just shows the growing size of the challenge. Direct standardized rates for mortality. So cause of mortality, if you like. Obviously, a high number of deaths were sort of coded as COVID-19. There have been some concerns through the clinical community in the UK that perhaps we've incorrectly coded deaths as COVID-19 when they more likely could have been a long-term condition like COPD or CVD or cancer. So we do need to look at how we're coding deaths in the future. And there's been some great debates in the UK, some really challenging debates around how we should classify directly deaths as a direct consequence of COVID-19. Case and deaths per 100,000 of the population. And I think this is where there's been a real concern in the UK, and where the UK does stand out, I believe, in terms of number of cases. So broadly, number of cases per 100,000, we're pretty much fall behind the international average. But when you look at the number of deaths per 100,000, we stand out in terms of percentage. So our death rate statistically is higher, whilst it may not be higher in terms of core volumes. Certainly on the percentage of confirmed cases, we have one of the highest globally. And that's of great concern to policymakers and politicians And clearly there's a need to ensure that we can identify people earlier. We can apply the vaccine earlier. We can get them under test and trace programs earlier, and we can really mitigate the impact of the virus. And this just gives you an example again of the directly standardized rates for mortality for COVID-19. And again, England, Wales, Scotland, the countries that make up the United Kingdom, really stand out against its European and even its American sort of comparators. So what we've tried to do in the UK in terms of practical and technical solutions is start to bring information together. How do we use the intelligence, the data, the insight, the experience, and the real world evidence for common good? So, as I said earlier, circa 2.5 million patients were shielded in the UK, and they were told shielded means they had to remain at home, they couldn't leave their home, they were provided with direct support from their general practitioner or clinician. And in front of you on the slide are the 4 categories that meet the shielded patient criteria. So category 1 clearly would be patients who recently had a transplant or due to undergo a transplant. Category 2 are patients with cancer and other life-limiting illnesses. Category 3 are those rare diseases. Generally, those are a higher risk of infection. Those patients who are immunosuppressed. And then category 4 are your high-risk patients. So these will be patients identified by the GP, identified by the nurse, who have been determined to be of high risk. So frail elderly, i.e. those patients over the age of 80, those patients with respiratory conditions, asthma, diabetes, and heart problems. All of these patients are identified by general practice surgery, and then they are under coordinated case management. So all of that data is in one place. There's been a recent announcement by the government that they're seeking to increase the number of people who meet the shielded patient criteria to 4.5 million from 2.5 million. And that's a direct intention to improve the way we manage COVID-19 as we move into the winter season. This just gives this map gives you a breakdown in terms of density of shielded patients. All I'm trying to indicate here and display is that data is localized, that data is concentrated, and it gives us an opportunity to really coordinate COVID-19 management moving forward. So as I spoke earlier, we're extending the number of shielded patients, and we're adding in vulnerable patients who would meet that need. So in extending from 2.5 million patients shielded to 4.5 million patients shielded and under active support, we're now looking at sort of shielding anyone over the age of 70 who's classed as vulnerable, those less than 70 but with emerging long-term conditions, patients who are pregnant and could be more prone to infection, and those who are categorized as obese, so anyone with a body mass index of over 40. Underpinning this, of course, is a significant vaccination campaign, which is due to start for COVID-19. And also we've got a nationwide flu vaccination program, which aims to ensure that all high-risk patients have access to the influenza vaccine. And this will be provided to circa 35 million individuals in the UK and will be the biggest vaccination program on record. Within the pack and the information here is just some data on the number of patients who are shielded and whether they're under active support in terms of employment or financial support. And what we've done as an organisation and what we're doing with local health systems is using that data to identify areas of the country that may require more concentrated support in terms of case management, may require a more dynamic response in terms of increasing number of COVID-19 diagnosis or deaths, and allowing systems to truly understand the data to best target responses moving forward. We're also looking at how we can be more proactive in the next phase. So recognizing that we understand where these high-risk patients are. We have data on each individual patient. We're working in partnership with clinicians to better manage them. How can we be more proactive now in ensuring that those patients' treatments are up to date? Are there any gaps in treatment and prescribing are met in advance of the winter? And this is an example for patients with COPD, respiratory conditions, chronic obstructive pulmonary disease. How do we make sure that they're having their asthma checks, that they're having their inhaler techniques updated, that they're having their medication reviewed, that they're up to date in terms of treatment before we get into the winter? We've also looking more broadly at some of the prevention opportunities. So one of the key messages from the Chief Executive of the National Health Service in England is making sure that all of the good services that we've developed, all of the innovative and good practice services we've developed as a result of COVID-19 are maintained. They're locked in for the future and they become the new normal. And there will be some broader societal educational opportunities. So with families spending more time together as a result of lockdown, how do we support the family unit to take more responsibility for their own healthcare? How do we encourage them to exercise more? How do we encourage them to think about eating healthily? Making people more open to making alternative lifestyle choices. So could they operate their life in a different way? Could they understand their own health condition better? Could they use technology and apps better to monitor their own health condition moving forward? And again, that last point around making sure that everyone, whether you're a politician, the government, a doctor, a nurse, a patient, a carer, we all seek to learn from this and maintain the positive changes and not slip back into the comfort of history. Just wanted to finish in terms of digital. As one of the things we have learned from China is the approach you've taken to track and trace and test and trace, where you've been able to identify citizens who have had a positive diagnosis of COVID-19 or are at risk of potentially having COVID-19. So we've looked now at an app. There will be an app that will be rolled out in the UK called the Test and Trace app. We've also seen a significant increase in non-face-to-face treatment in the NHS, video consultations, the use of technology to coordinate patient care. And I think we're on the cusp of a digital revolution in the UK now as a result of COVID-19. So I just wanted to touch on briefly some of the opportunities linked to the digital space in the UK, the opportunities for investment, the opportunities to work in partnership, and at last a long thought for recognition in the National Health Service that we can't go back and do things the old way. We have to use technology to support patient care. So Europe and the UK is now a more attractive and robust financing market for digital products, digital apps, and with participation from foreign investors. We've seen a significant increase in funding and capital for biotech medicine, digital products, and other technologies. And there's been a surge in mergers and acquisitions and IPO activities, and a number of other countries now working with the UK to take advantage of those favorable markets to purchase digital companies and to roll out digital solutions at scale. And I think if you see here from some of the statistics, the aggregate value investment by series has increased, and that's likely to continue in the UK. And I do believe there's a lot that we can learn in the UK from the approach that China have taken to digital technology, apps, services, monitoring tools. And I think one thing I'd be keen to learn on from you and all of the esteemed colleagues in the audience is how we can learn from how China has mobilized technology, has rolled out digital, and how they've helped to establish digital as a normal part of a patient care pathway. And then just to finish, some concluding remarks, some key lessons, I think, both for the UK and China from the COVID-19 crisis. Using data and a lot of data that we've generated to connect the key social causes and factors together. This isn't just about healthcare. This isn't just about social care. This is about health, social care, educational information, employment information, and we need to use that and combine that for common good. We do need a systemized approach to pandemic management. Certainly in the UK, we haven't been proactive enough. We've been too reactive. What can we do differently moving forward? How do we set systems up so they're able to sort of understand what's happened before, react to the right surges in activity, react to the increases in diagnosis, and ensure that we lock down and scale services up in the right way. There's a lot of good innovation that has taken place across the health and social care supply chain, both in the UK and China. How do we lock those in? How do we keep them focused and sort of directed in the future to continue to improve the quality of care we provide to our citizens? And I think working together on best practice, bringing that innovation together, will give us a significant opportunity again across China and the UK to exchange ideas, build academic partnership, some good commercial opportunities in partnership as well. We're in the UK a huge focus on stratifying patients by risk. And I think in stratifying patients by risk and using data to identify high-risk patients together, there is an opportunity to sort of develop new approaches around case management of patients, understanding how we can best predict future need and act accordingly, how that helps to drive early intervention and prevention so we can manage long-term conditions at point of diagnosis, and we can involve the patient in the conversation about reducing the impact of those long-term conditions. How jointly we can develop a bank of real-world evidence and research data that doesn't just help us today, but helps to shape new thinking around pandemic management, for the next 10, 20, 30, 50 years. As I said earlier, how we can work together on maximizing the use of digital and other technologies. And in locking in that innovation and best practice, how does China and the UK work together to really drive some strong, high quality, patient-focused technologies, developments into a change in health service moving forward. So I'll stop there. Once again, thank you for your time. Thank you for giving me the opportunity to share our experiences and reflections with you. I look forward to hearing from you, and hopefully I'll see you in 2021. Thank you.